Welcome to Cleveland. Welcome to the home of the Cleveland Browns, which happens to be a major underlying driver for refractory chronic headache here in this part of the state. So it's fitting that I talk about this topic today, cracking the code, solving refractory headache mysteries. I was trying to figure out how to go about this topic, and I decided to really just do it from the perspective of what I see every day, all day, we all do in the headache center, which is patients that come in from across the state, out of the country, with chronic refractory headache disorders, and they're just not getting better with treatments, and it's a medical mystery why. And so when you look at a lot of these patients, most of them actually fit criteria for chronic migraine if you really dig into the symptoms. And so I'm going to really focus on this subset of patients because it really makes up the bulk of these patients that we see. And over the years, I've kind of observed these patients, and I lump them into two categories. The first category is the patients that have pure chronic migraine, unadulterated chronic migraine. They've all by themselves evolved from this episodic to this chronic migraine cycle, which is going to be the natural tendency in the course of this disease progress if you don't interfere with that with effective abortive and preventive strategies. And sometimes they just don't respond to things, and we'll touch on these patients. And the other group of patients, which we're going to focus more on, is this group of patients that also have chronic migraine, but they have a unique feature. They have something that is sustaining and driving that chronic migraine cycle. And it's these patients that often get overlooked for years, and if you don't identify the underlying driver for the chronic migraine cycle, these patients are just not going to get better. So I'm going to go over some of the most common things that I see associated with chronic migraine and why many of these cases continue to sustain without benefit with treatments. Ultimately, what I hope to do is just remind you to step outside of this black and white chronic migraine label and make sure you've looked peripherally at all the inputs that can go into chronic migraine and really help sustain and fuel the cycle. First of all, like I mentioned earlier, migraine can naturally evolve from episodic to chronic migraine. This is often the disease course if you don't have somebody that interferes early with having an effective abortive and an effective preventive strategy to prevent this. You know, the more they go over the years without good treatment strategy, the more the migraine kind of feeds upon itself and gets more and more frequent until they end up eventually in chronic migraine. But there's a number of patients that also this chronic migraine system can be activated and turned on, and it can be driven by other factors. And many times these factors are overlooked. These factors may have started at the onset of the chronic migraine. They may be things that they collect over the years, and they continue to fuel the headache. And the problem is that if these contributing drivers are not identified and treated simultaneously with the chronic migraine, the chances of that patient improving become very slim. This is why when I see these patients referred, I always ask myself, what is the chronic migraine on switch here, and what's keeping that switch turned on? You know, is it truly just pure episodic migraine that's converted to chronic migraine, or is there something that's continuing to drive it? And so how do we crack the code and turn that back off? So that's how I approach these patients. This is just from my perspective. This is a lot of these refractory cases that I see of chronic migraine. These are probably the most common things that I see that continue to sustain the cycle. A rebound headache, medication overuse headache, occipital neuralgia plus or minus cervicogenic headache, NDPH, and post-traumatic headache or post-concussion headache. So we're going to dissect each one of these. So occipital neuralgia, first of all, there's a variety of pain descriptions. Most often it's electrical, shocking, zapping, stabbing in the back of the head. I tell patients think of it like a sciatica of the head, essentially. But it can also be pressure, dull, achy. It can be throbby, so people can kind of misinterpret it for migraine. And it extends throughout the occipital area. If you feel the occipital bone there and just drop below there, that's where the occipital nerves come out through that muscle, and then they wrap over the edge and travel through the back of the head. And basically, they cover through the occipital into the posterior parietal areas. And there's often some associated with neck pain, so there can be cervicogenic headache in the mix that these both can contribute to a chronic migraine driver, but there doesn't have to be. It's not uncommon to see pure occipital neuralgia happening back there. Causes of this are, as those nerves pierce through that tissue and travel through the scalp tissue, it's a very fibrous tissue, and so over time those nerves can get tangled, twisted. Some of these people have, they've hit the back of their head at some point, or they've had a whiplash injury, bad arthritis in the neck. Sometimes we see this post-viral, where the virus can actually get in and cause this chronic inflammatory neuritic pain. But there's a lot of patients that there's not a clear cause for it, and it's not something you're going to see on test. You're really diagnosed by clinical exam. because you touch them and they're exquisitely tender, but it's really based on clinical exam to diagnose this disorder. You can do occipital nerve blocks diagnostically. That can give you a pretty clear idea. Most of these patients we're talking about have chronic migraine on top of this, so I like to get a baseline brain spine. If there's a lot of neck pain, I get a cervical spine MRI as well to rule out structural posterior fossa lesions. All right, we're going to move on to probably the number one cause that patients come in. They continue to have this chronic migraine despite trying all these medications. But the blaring thing to me is always that they are, using excessive abortive medicines. And so I always tell them, until you get rid of this factor and this driver for your chronic migraine, your headaches are probably not going to get better. And so these are the medications in general, not that this is for everyone, but in general, NSAIDs, over-the-counter, triptans, more than 10 days a month, can drive episodic into chronic migraine. And this is over, 2-3 months plus. It's not they have a bad month and they get in a rebound, that kind of thing. It takes a little bit of time to build up. Opiates, about 8 days a month is the magic number. And then butalbital medications, Fioricet, these kind of things, also known as the headache specialist's worst enemy. More than 5 days a month on average will drive into that cycle often. Treatment essentially is withdrawal. There's no way around it. I tell people it's going to get often worse before it gets better. You have to kind of weather through the storm to get to the smoother waters. And once they understand that there's light at the end of the tunnel, they're a little more willing to go through that. But we do a variety of bridge therapies, whether that's steroid bursts, nerve blocks, these kind of things. Preventive medication should always be used in this process. There was a paper a couple of years ago that came out, and they looked at weaning strategies, whether it's just cold turkey, whether it's just a slow wean without prevention, and then a slow wean plus prevention. And by far, the strategy that worked the best was slow wean with preventive strategy, with a preventive medication in the mix. So this helps to bridge people a little more gradually. And I tell people it's not going to be immediate. People say, I stopped Excedrin last week. My headaches are still bad. And so they just need to understand that this is a process. It takes some time to turn that around. And sometimes it can take 6 weeks or so, depending on the medicine that's being used, depending on how much is being used. This is how I do it. I like to do a slower wean. We do faster weans. We usually is in our infusion suite, and if they're overusing Fioricet, sometimes we'll bridge them with phenobarbital. It gets kind of messy. So I like to do it this way because it's usually easiest for patients. So say they're taking 6 Excedrin a day. I'll tell the patient, take half of that a day. So take 3 a day for a week. And then the goal is every week, try to get rid of 1 day out of that week until you get to that goal of 10 days per month, or depending on the medicine that you're trying to wean down on. Third most common thing I would say that I see is post-traumatic headache, post-concussion headache. And this part of the story is often kind of ignored and overlooked. But, many times if you go back in the history, the patient had some kind of a concussion, sometimes very minor events, and they start having these daily headaches, or these very frequent headaches from that point. And so technically this is a headache that develops within 7 days of head injury. It can evolve into chronic, which is 3+ months. And I tell patients this injury basically can turn on and activate that chronic migraine circuitry switch. If they have a pre-existing history of migraine, they tend to be a little more susceptible to head injuries and concussions that may worsen their headaches like this. And it often has a chronic migraine, chronic tension type overlap to it. The other thing I want to put in here is, we see a lot of patients with post-neurosurgical procedures, craniotomies. This is a major trauma to the skull. You're cutting a piece of the bone out. And this can also activate that electrical system. These kind of headache disorders are often associated with concussion symptoms, dizziness, brain fog, mood changes, sleep disturbances. So these are things that you also want to incorporate into your treatment plan. It can be associated with cervicogenic and occipital neuralgia because a lot of these people have had some kind of head injury, often in the back of the head, so it kind of activates those nerves. And so it's important to definitely focus on treating those issues simultaneously along with using chronic migraine medications and treatments. NDPH is the other thing that really, we see this often if you take a detailed history of these patients. It's really key. And so when I see headache patients in the office, the first thing that I ask them about their headaches is that I don't want to hear about your current headache yet. I want you to go as far back as you can remember that you started having any kind of headache, even if it's totally unrelated to what you have right now, because sometimes that can kind of lead you into what's happening with the current headaches. So we'll go through that, and then eventually, we get to the current headache. And for NDPH specifically, the key is, so this daily headache that you have, did it start episodically, and did it evolve over time to chronic daily headache, or did it start as daily from day one? That's really the key differentiating factor, because these headaches often have a chronic migraine appearance to them, and they just get treated for years as chronic migraine. But when you dissect it, it actually is NDPH that kind of initiated the process. This is a headache that starts, again, abruptly, daily from onset. Person comes in, June 6, 1986, I woke up with this headache and I've had it ever since. That kind of a story. And so chronic migraine doesn't just start as a daily headache from day one. That's the other key here. So if it starts like that, it's probably not chronic migraine. It's probably something that's fueling that chronic migraine appearing headache. So it has to be there for 3+ months. All the testing is negative, which we'll talk about here shortly. And it's one of the most resistant forms of headaches. If you look at the literature for NDPH, besides just spontaneously coming on out of the blue, and I will say the person may have never had a headache in their life, they may have a background of migraines, it's really just this new defined onset of chronic daily headache. But the other things are some kind of a mild upper respiratory infection, cold symptoms, GI bug, some kind of a strong emotional event, and then some type of a minor medical procedure, and it can be even an IV line placement. But these are the things in the literature that have been most often linked and associated with the onset of NDPH. The headache really it lacks characteristic features, but like I mentioned, it does often have this chronic overlapping chronic migraine and tension type pattern to it, so we usually end up treating it like chronic migraine. But, it's very poor response typically for a lot of the treatments that we use. So let's talk about treatment consideration for refractory chronic migraine. Many of these patients have failed a number of things, and they many times may need a synergistic treatment strategy where you're combining different treatments that are targeting different pathways with different classes of medicines. And so these are some of the ones that have some evidence in the literature, and these are ones that we often use. Anabotulinum A, toxin plus CGRP monoclonal antibodies. I've seen quite a few patients do very well with that. Anabot plus GPANTs. Sometimes we'll use that combo. There's a little bit of literature for the monoclonals plus the GPANTs. The problem with this is usually insurance gets in the way of this one. And then, of course, the older anticonvulsants, antihypertensives, antidepressant medicines. Sometimes stacking these in with these above strategies can be another strategy because the key is that you want to hit as many pathways as you can with these chronic refractory patients to see hopefully what clicks for them and gets that switch to shut back off. This is just one study. For the sake of time, we're not going to go through a bunch of these, but the use of a CGRP monoclonal antibody with anabotulinum toxin A, this was a retrospective review of 66 patients with chronic migraine. So their baseline was about 26 days per month, so pretty heavy duty. With Anabot by itself, it decreased to about 15 days, which is certainly good. But when you add a monoclonal antibody on top of that, it went down to about 9 days. So you can see the synergistic effect. And there's been similar studies showing the same concept. In conclusion, occipital neuralgia and cervicogenic headache, along with MOH, are two common contributors to sustaining a chronic migraine cycle. They may not have started it, but they may at some point come into it and may continue to sustain that cycle. So these are things that you can actually target and modify and reverse. Chronic post-traumatic headache / concussion headache, NDPH, these are common underlying causes of chronic daily headache. They can have a chronic migraine appearance, so it's important to just add additional treatments that may focus on these additional contributors to the headaches. For treatment of refractory chronic migraine, look for separate contributing on switches driving this cycle, because if you don't treat the contributing on switches and drivers in conjunction with using chronic migraine therapies, you're unlikely to get that patient better. People have different electrical pathways that can sustain and drive chronic migraine and headache cycles, so this is where the thinking of using synergistic therapies that are targeting different mechanisms can help with these patients to hopefully get them to get their code cracked and get their headaches better. And essentially, as I explained to them, finding something that clicks with their personal circuitry. These are the references here.